diversion device or themselves is because of bladder cancer or other pelvic malignancies. And then the other reasons are listed there for you. Bladder cancer is linked to tobacco use. So not only with smoking, with chewing tobacco, even though they spit it out, still get in the system, big correlation with tobacco and bladder cancers. Also correlation with bladder cancer and prostate cancers because it's so close in proximity. So those are where the things happen and occur and all that kind of stuff. So, cutaneous urinary diversion simply means that it's brought out to the skin. And so that's what you'll see. I don't want you guys to memorize the different ones. It's more of in general stuff. However, one thing is the diversions being cutaneous means that you will see everything is coming to skin. Whether it's this A with the iliac conduit, or your urostomy, or where it's coming straight from the bladder itself, or it's coming right from the kidney tap itself. Again, stomas all are the same, just like it is for bowel, it's the same thing for urinary. It's got to be moist, it's got to be bright, not necessarily bright red, but bright red. And it has to be, I said moist already. So, that's some of the things. Keep in mind urine, right? Urine we say is sterile. However, one thing we have to worry about with these patients is it's got to weigh in to cause a bigger systemic problem if they have any kind of microorganism exposure. Also, when urine sits on skin, it's going to erode that skin. So it's the same concept that you guys learned with bowel elimination, with the phalange and the pouch, right? You know, you got to protect the skin around the stoma, not only the stoma itself, but the skin around, because how else are you going to put an application of a flange around the stoma to protect the skin and the stoma kind of scenario? And being that there is urine acidity-wise, right, so we worry about the skin around these. With the continent urinary diversions, Indiana pouch used to be very popular, coming back now, as one type. Then you'll see where, again, the stoma, but you notice that it's continent. It's going to different areas in the body, per se. One of the final ones is a urosigmoidostomy. And so if you notice, all the urinary stuff, the ureters are attached to the sigmoid colon, and they defecate and urinate from the same sphincter. Okay? So it's very hard to be able to get a urine specimen when it's mixed with E. coli, right? By the time it gets to this point, these patients are sick, right? Last resort kind of scenario. I hate to say it like that, but it's true. And so they use already inside equipment, I don't know how else to say that. Segments of the ileum and the cecum, but you can see that they're using different stuff for that. And it's all because their bladder was full of cancer and it had to be removed. That is the whole purpose of this. Preoperatively, not only the sense of it having the cancer, so all that psychosocial anxiety, fear, knowledge deficit of what device they're going to get and how they're going to care for it. One thing is we hope they have a caregiver that can help explain, because the goal, of course, is for them to go home and care for it themselves. Same thing with the post-op wise is that altered body image as well. Pain, psychosocial definitely plays a role. I'm not saying not less or more in the continent or the cutaneous, but in general, I mean, their bladder's gone, so their body is changed based on the word cancer. So definitely need to be considerate with that. Questions about any of that